Hi, good evening. Uh, One of the ironies of this debate is 8 years back in 2015, I was debating my very, very close friend and batchmate Abhay, whether MIS surgery is indeed required or it's all humbug. And I'm glad now we have post-graduated to whether it can be done in difficult situations of spine. Dr. Menon has made a beautiful case of what needs to be done and how high-grade listhesis is different in every case. Well, we've moved as every surgery should and has evolved over a period of time where we have done long segments, constructs, and trying to save as much as possible, going down, doing it front back, and now to doing them totally MIS. So like this patient. So the goal of any spondylolisthesis treatment is to fuse the least possible and to balance the spinopelvic parameters. Can this be achieved? And majority of this, my initial brief was grade 3 listhesis, and then when I came here, I realized it was on ischemic only, so we've made a few changes. Bear with me if there are some that do not classify into the topic here. But ischemic spondylolisthesis, especially in our country, usually presents in late 20s and 30s when women have, majority of them are women, unfortunately, have gone through a lot of pain. And fortunate for us was this demonstration case we did about 2 months back at the BSSCon, a 19-year-old. Here, she fits into the grade 5 SDSG classification, and that's her picture. And you can see severely stenotic, central as well as lateral recess with anterior slope of the sacrum coming in the way. And we did this in my alma mater at KM, and with that we could manage this. This is a post-op with a fairly, this is too early to do actually standing lateral to do the pelvic parameters, but what we got from the immediate post-op, the parameters are here. So this is another case, 36-year-old, symptomatic for 13 years, managed via MIS TLIF. This is another one, another 31-year-old, managed with MIS TLIF. So the literature to support MIS TLIF, especially in 5 and 6 SGSG, is very little, but has started pouring in. This was our first paper in 2018 in the Global Spine Congress in Toronto, where we had 12 patients. This is the chart of of high-grade listhesis. These are the images that were part of the presentation. If you see here, we started off with a little longish time. It took nearly 4 hours to do it. But if you see the accuracy of the screw and the correction is very good. The complications, we are lucky. There is nothing like a zero complication surgery, but so far we got away with that. And the corrections, as you can see here, were fairly decent. These are the mandatory X-rays at 6 months that we do with all our fusion cases to check for fusion, showing Bridwell grade 1 fusions. And well, of course, the obvious advantages of all routine MIS surgery that we use for any routine fusion are extended to an high-grade listhesis, making it more easy. This is another of our case reports that we had of a syndromic high-grade listhesis lady, was in pain all her life, as she was saying, very osteoporotic, and that's what we did. This is her sitting at 1 month. This can be done because it is a secure fixation. There are certain things that you have to understand in a high-grade listhesis. If you wish to have this secure fixation at 1 month, this is in, I'll come to that later. This is in a fat patient. You can see the depth there. These are Indian implants that we have used. These are the osteophytes that she gathered over the decades, but you can see a grade 1 union going through this. This case is now 8 years old. These are several other patients that we have done in the past. A rigid one, again, interdiscal work, expansion, and the basis, majority of your high-grade listhesis are going to be at L5S1. The cornerstone is the strong base. Majority of them will be osteoporotic and will have a lot of sclerosis at the tip. So unless you have drilled through this osteosclerotic bone, you're not going to get a good foundation. So you've got to have a long, you've got to have a 3 cortical and a medialized screw. You can do it with navigation, which we currently use, which is the best. Having said it, our initial cases for the first 6 years were without navigation, where we would do it with a C-arm and a Lenke. But unless you're targeted this, you're bound to fail in an MIS fixation. You need to have a complete armamentum of curates, especially the long angled ones to reach under the anterior ends of S1 as well as L5 when you're releasing, because unless you have a good anterior release, your screws are not going to hold your reduction for you. This is another thing we use. These are serial blunt puka chisels. They start at a height of 6 millimeters and thickness of 2.5, and the last one is 16 millimeters and a thickness of 6 or 7 millimeters. So this is like lifting a car that is punctured over a jack. You serially dilate the front so that it restores back. The whole idea is, there are plenty of orthopedic surgeons here who must have used external fixator, the principle of ligament retrexus for distal and radius, where you're using the soft tissue cover to pull and give stability to the bone. When you have a listhetic situation, imagine this to be the end plates of the vertebrae, and that's the listhesis happening. This is the crumpled annulus and the ligaments. When you serially dilate them and open it up, what you do is you give tension to this soft tissue. And it is a 360-degree coverage that the vertebra have. And as you serially dilate them, they tense up and they pull the vertebra that has moved away back into its position. And when you do that, you put in a right-size cage. This makes the compression surface a weight-bearing. This cage becomes the weight-bearing part of your construct and not the screws, which is the basic fallacy. When you put a screw in 4, you put a screw in S1 and you expect the L5 screw to reduce the listhesis. That is where you are transferring the weight bearing to something that is, screws are essentially torque neutralizing, they're not weight bearing. That's where implant failures happen. So you know this procedure, you do wide, and if you are somebody who doesn't want to put your dilator right up in the front, then MIS is not going to happen for you. But you had, this is the C-arm views where you put in a nice big cage. As you go up, you see the reductions happening. And these are very stiff cases. You can use a lordotic opening cage to add to the segmental lordosis also. Also, we use lordosed rods. These are reduction screws extensions which are locally manufactured by several companies. What we do is a lordosed rod, tighten the S1 and then tighten the L5. So the remaining listhesis corrects by a grade 1. So you can see this is what happens when you have tightened it. And of course, our rock star president has already described his paper, which was quoted by Professor Menon before, where he used the jig-based maneuver, which is also a good way of reducing. Well, steps to listhesis reduction, majority of them will reduce by a grade on positioning. Facetectomy. There's something called as an internal facetectomy that we do, where we do a facetectomy on the index side you're going through. You take out the base of the spinous process, and between the two layers of lamina, put in your chisel and go and do right up to the facet of the opposite side. That should release some part, but if it's a very stiff one, we do now what is called as an internal parts. There is a complication actually which led us to that. If you are doing an MIS relief over the top, and your upper quadrant on the outside, if you nibble too much of the bone, you get an iatrogenic pars fracture. That's what you should be doing to do an opposite side release. That helps you in releasing that. If even that is not possible, it just takes another tube to be docked on the other side, take out that facet, and you have a completely released behind. The front preparation has no substitute. If you do your front preparation good, use blunt pukas. Using sharp shavers is going to take away the bony end plates and your cage is going to sink. That's a disaster. That is one reason we stopped doing dome osteotomies. The dome of the sacrum over that many years has become sclerosed, is one of the strongest foundations you can park your cage on. If you saw the case I showed of a 19-year-old, very soft bones, but that dome is hard. That's where the cage is going to do. So what do you do to the front? You have to put an angled curette the part beyond the dysplastic part that has sloped down, curette that and pack bone graft there, so that also heals completely. So that gives you an adequate this thing. Use decent bone graft. Like Dr. Tanna said, there's nothing like too much bone graft. It is going to aid you in your healing. Lordose your rods so that you get your sagittal corrections. It can be done in such neglected cases also at 2 levels. We have now close to a dozen of these done at 2 levels. We have stopped using expandable cages anymore. And It's not a rocket science. I trained as a classic open surgeon in the early 90s. The first 10 years of my practice were open. We used to go 2 levels above, put iliac bolts and fix them. But then, unless you are going to continuously reinvent yourself, you are very likely to become like an ambassador car. It's a classic, but nobody buys it anymore and the production has stopped. There will be some cases which are beyond the realm of minimal access surgery right now, but there will be only some cases. Majority of them can safely be addressed by using minimal access techniques. Thank you.